So I think that we're recording now, and I'm just going to repeat myself just a little bit so that it's also on the recording. So today is the Wednesday evening, and we're on a week 14. And of course, our weeks got a little bit turned upside down with everything that happened during the spring break with the IT challenges that we were battling. So for that reason, we've had to change the schedule a little bit, but this week we're taking the exam 3 and practical 3. And what I really want to do is go through a couple of basic things, and then I want to really focus most of our attention on the study guide for the exam 3. And as always, the study guide is there available on the canvas if you wish to download that, or if you wish to print it, or you can just simply have it as a resource on your screen, or not even keep it on the screen and take notes as you need. I think that I have answered to every single message that I have on the canvas. Sometimes I get a little bit of them building up, but everything should be up to date. But I do want to remind you, if you need any extensions, any due dates changed, or if you need anything reopened, always contact me, let me know. I would encourage you to try to do those before taking the exam, so you get a chance to kind of practice on that. But it's up to you what you find useful for you. The other thing that I really wanted to just quickly mention is that after this week, we are 3/4 done with this course. There's a little bit extra points available than 1/4, because we have also the finals week activity, but really you are on the finish line. So give yourself a big pat on the back and know that you're almost at the goal. This week I don't have any new assignments. So basically it's a week to take the exam 3 and take the lab practical 3, and also catch up on any work that you might have waiting on that you didn't get a chance to tackle. I've been putting extensions quite a lot, and I'm super happy to do that. So just let me know. And like I said, this week, by the end of the week, which I believe Sunday is the 25th, I'm asking you to complete the exam 3 and lab practical 3. Couple of practical things to mention about those is that they are, again, open book tests, so you can use your notes. You can take any tools that you have that help you. You can take them from home. They are to be taken on a single setting, so once you start, you kind of have to finish it on that go. And I do know that sometimes we do have computer issues, any of us. So if that happens, you just let me know and I can reset your test. Other thing, if you have a plan in place, and I have given a password for you to take an accommodation version of the test, use that. It's the same password and same version what you've done before. And the final thing that I wanted to say about the exam is that all of the questions on the exam, as before, are from the lecture videos. So they are covered on this study guide that we'll go through. One way or another, all the questions are pulled from there. On this exam, I don't think that I have any extra credit questions, simply because I didn't really get a chance to sit down and write any, but there's a lot of extra credit available, for example, as a finals week project. With the lab practical, as before, don't worry about the spelling as long as you give it a good go. And if you don't know something, at least guess or give me something that I can give you marks for. That's probably the best way ahead. In terms of the exam 3 study guide, I'm going to jump right into it, and I'm not meaning to bulldoze through the material. There's just a lot to cover. So if at any stage you have questions, don't feel that you have to wait to the end. You just shout out. You can write it to the chat, or you can just unmute yourself and let me know, and I'll definitely try to answer. But I have now 3 recordings available for you where I go through the study guide in quite a bit of detail. So what I'm trying to do tonight is to go through it in a little bit more general level. So if you want a very detailed description, I recommend using those already existing recordings, and I'll try to keep this a little shorter. So far, pretty much every one of those recordings has taken closer to 2 hours, and I know that it's the Wednesday evening, so you probably have other places to be. If you have to go, I totally understand that as well. So I'm going to jump off from here and try to open for us the study guide. And like I said, the study guide is available as the blank version on the canvas. And you should be able to see now my PDF file on the screen. And we'll work through that to cover the 3 chapters that we'll be talking about. We'll start by talking about the respiratory system. Then we'll have a look of the urinary system. And in urinary system, we really focus on a structure called nephron. And then at the very end, the last chapter, which is a little bit of continuation of the respiratory system, but also a little bit of just review of concepts that you probably know from the past, and to some amount, just kind of tying in the concepts. We'll cover the chapter on water, electrolyte, and pH balance. So that's the plan, but like I said, I'm going to try to go through this a little bit quicker than what I've gone in the earlier sessions this week. But if at any stage you have questions, you just shout out. I don't always see the chat when I use the PDF file reader, so just feel free to shout out if I miss it. So we're going to start with the respiratory system, and one thing that's always that I try to do is to do these systems links from one system to another, and we're going to look at these other systems that we've seen from the angle of the respiratory system. How do they assist respiratory system on its job? So what we saw, we talked about the cardiovascular system, and one big thing that we saw with it was that it's an excellent transport system, and what it does transport, it's especially the oxygen and the carbon dioxide as they relate to the respiratory system. Of course, the cardiovascular system transported also nutrients, waste products, hormones, and so on, but those 2 gases are the most important for us. So respiratory system works hard to get them to our body, and then cardiovascular system assists on transporting them. And also away from the body, it assists so that we get carbon dioxide from the tissues to the lungs and can breathe it out. The other thing that we notice is that respiratory system, like many other systems, are facing challenges also from external world. So most of our body is protected by skin, and skin is a reasonably thick layer barrier for a lot of infections, a lot of pathogens that otherwise could cause issues for us. But when we start going inside the body, such as the digestive tract, respiratory tract, urinary tract, reproductive tract, all of those have opening to an outside world. And through that opening, a pathogen could get into those tracts. So we don't have skin inside those, but we have is a mucous membrane layer. And we'll talk about that layer in a little bit, but the layer is there. And in addition to that, the lymphatic immune system play a role in protecting us against various pathogens that might either get in, or if something has gotten in, they fight to get rid of that. For example, if you're a heavy cigarette smoker, your lungs are working really hard, and your immune system to clean the lungs that get contaminated as a result. And final system that ties in quite nicely with the respiratory system as well is the urinary system. And you remember that the main function of the urinary system was the blood pressure regulation, but in case of the respiratory system, it also plays role in eliminating the excess hydrogen, for example, from our body in form of a urine. So it helps there as well. So really, I think that that's the biggest points that I can think of that we should know in terms of how other chapters relate to that. And I listed at the very beginning of when you started looking at the respiratory system, 3 things that are most commonly taken care by if you're a, for example, paramedic or first aider or deal at the emergency room with the patients coming in. There's 3 things that we're most concerned. We're concerned that is the airway open, and if the airway is open, then we're concerned, does the patient breathe? And then the third thing is that we want to make sure that the cardiovascular system is working, so blood is moving within that system. So if you look at that, 2 out of 3 things on that list of the 3 important things are dedicated for respiratory system. So if there's a blockage at the airway, we open that. If there's no breathing happening, we use rescue breaths. And then if there is no heartbeat either, we can use chest compressions. So that just shows how important the respiratory system is for us. And if you want to go back to the days on BIO181 or BIO156, you'll remember this formula from cellular respiration. What we see there is that we have a sugar molecule, in this case, a glucose molecule that I've listed a formula there. And sugars are turned into ATP, which is the cellular currency of the energy in the cell level. That's all that your body does. That's known as cellular respiration. However, to do that, you do need to also get oxygen into the body, and you need to get rid of carbon dioxide, which is the waste product of this process. And quite surprisingly, or I don't know surprisingly, but relating to our later chapters, as a byproduct, we also produce water, and we need to get rid of that. So really, these gases are going to be important for us to have a look of, and that's what we'll be focusing on this first chapter. So really kind of summarizing what I've already said earlier on, supply of the oxygen is going to be important, bringing that into the body, and then the removal of the carbon dioxide, getting that away from the body. Those are going to be the 2 main functions of the respiratory system that it serves in terms of what we've been looking. In addition to that, respiratory system plays important role, for example, in olfaction, the sense of smell, and in terms of the production of speech, which is obviously very important for us humans as a communication tool. And then there's a bunch of non-respiratory movements that are then also at the respiratory system. I'll come back where we were earlier on. I was just trying to find what I wanted to show. The non-respiratory movements here, such as coughing, sneezing, crying, laughing, hiccups, and even yawning. So respiratory system is involved in a lot of things. Well, now that we have looked at the very basics, I think that we're good to move on. And what we're going to start with is that we're basically going to go through the respiratory system one area at a time. What you might see sometimes is that respiratory system is divided into upper and lower respiratory tract. That division is a little bit artificial, and for our purposes, as long as you know that we have these parts of the respiratory system, I'll be quite happy with that, I think. So let's start with the nose. And we, of course, know that most of the air to the body is taken in through the nose. So we normally breathe through the nose, and that plays an important role. That's for a good reason. If we are not able to get enough air to the body through breathing through the nose, or get rid of enough of carbon dioxide by breathing to the nose, we can also recruit mouth to serve as additional route, but that's really not ideal, and it will become obvious why it's not ideal a little later on this.
Are you going back to the top part, or you jumped that?
This part?
Yeah.
I can keep it up there. So
Yeah.
Yeah,
I
I know
need
that I
it.
went through it real fast. So a good example of when we recruit the mouth to assist is, for example, when you have low levels of oxygen, people start yawning. So that's really the physiological explanation why people yawn. There's a little oxygen, your body gets alarmed about that and wants to do something about it. And there's no better way of getting quickly a lot of oxygen in than really opening your mouth big and taking a big breath in. So the social and cultural and maybe psychological explanation, which relates the yawning to more of being bored or uninspired, that's not what we see in the physiological sense. Sometimes I hear that students tell me that yawning spreads once a person next to you yawns, you start yawning. Well, from a physiological sense, that makes sense because that probably means that in that room where we're at, the air has little oxygen in there. So everyone's starting to show these same physiological responses to that. So that's really what yawning does. It's just a way of recruiting the mouth to assist with the oral cavity to get in additional oxygen. The other thing that I wanted to mention in terms of the nose is that we end up finding within the nose at the nares, nostrils, hair. And this hair serves an important role. Again, I'm going to do a really quick sketch here. Nose, mouth, chin of an individual, their nasal cavity and their oral cavity. And what we see is that there's hair right at the entry to the nasal cavity. And this hair serves a purpose of being kind of a filter for any larger particles that we might wish to remove from the air that one breathes in. So that's the first screening or cleaning side there. But of course, these hair don't catch everything. So the next structure that I want to speak a little bit about, and if I go too fast, just give me a shout out, is going to be the nasal cavity. So like I discussed earlier on, we don't have skin within the nasal cavity. However, we have something known as mucous membrane. A mucous membrane is thinner than the skin. It is covered by mucus, and mucus is this kind of a sticky, wet stuff produced by the goblet cells. And goblet cells are numerous in the nasal cavity, the mucus, producing the mucous membrane there. And this really serves quite a few purposes. So first of all, what you see here, it humidifies the air that would pass through the mucous membrane area of the nose. So we make the air that's going to go in further to the respiratory tract wet. Other thing that we do, we also heat the air. And final thing that we do is that we remove any particles that might be in that air. So the hairs don't catch everything, so there might be smaller parts. The mucous membrane is really good at trapping stuff that shouldn't be getting to the lungs. They often get caught to the mucous membrane at this point. So those are the three important functions of the nasal cavity. When we look at the nasal cavity, one thing that we'll notice is that within the nasal cavity, there's three bumps from the lateral side of the cavity that are quite obvious. So I'm here drawing a view from the front. We've got eye sockets, and then we've got this nasal cavity with three bumps coming from the lateral side towards the in. And then we would have our teeth here, upper jaw, lower jaw, mandible, and so on. That would be our skull. I'm going to jump. However, we're going to come back here to this diagram that I drew earlier on. And what we see is that on the lateral walls of the nasal cavity, there's these three bumps coming in. And if we look at this view from the front, they are going to be these bumps here. And what these three bumps do they are known as conchae, and they're named based on their location. So we have superior, middle, and inferior. And these conchae are going to be really important for us in terms of helping nasal cavity to do its job. And what it helps nasal cavity to do is, first of all, it increases the surface area. So just like we had microvilli, villi on the surface of the cell to make the surface area bigger, conchae do that. The other thing that conchae do, they generate turbulence. You can think of that, of generating this flowing airstream, a little bit like a tornado turned horizontally, which ensures that as much of the air as possible will reach and touch this mucous membrane. So as much of it as possible, we get humidified, we get it heated, and we are able to trap any particles that get into contact with this mucous membrane. So that's what I wanted to mention about those. Other structure that I do want to mention at this point is the nasal septum, which separates the nasal cavity into left and right side. And it would be on this diagram of ours here. One more thing, or two more things that I'm going to mention there is that we also end up finding that the floor of the nasal cavity is made by the palate. And it is especially at the anterior part, so the front part of this floor of the nasal cavity, that we end up finding that is known as hard palate. And this is because there's bone within this structure. So it's kind of a little bit harder physically. Behind that, on the posterior part of the palate, we end up finding soft palate. So soft palate is only soft tissues that we end up finding there. And we can add it also onto this diagram that we were working from. Of course, at the very end of the soft palate, we then have also uvula, which is that hanging thing at the back of the throat. And we'll talk more about that when we talk about the digestive system. So that's the floor of the nasal cavity or roof of the oral cavity. Within the region where we have the nasal structures and in the region of the skull in general, we end up finding structures that are called paranasal sinuses. And if you remember our earlier discussion, whenever we talked about a sinus was some kind of an empty space cavity within an organ or within tissue. So paranasal sinuses are just that. And to go through the paranasal sinuses, I'm going to again do a quick sketch of a skull. So we're going to first do a skull from the sideways. Here's the eye sockets. We have the nose. We have the upper jaw teeth, lower jaw teeth, mandible, and then rest of the skull. And we're going to do another drawing of the skull from the front. So 2 eye sockets, the nose that we saw earlier with the septum in the middle, upper jaw teeth, and lower jaw teeth on the mandible, and rest of the mandible. So they're really quick sketches, but we're going to use those as we work through the paranasal sinuses. And what's nice about studying the paranasal sinuses is that all you have to do is know your bones of the skull and you're all set. So we're going to start with the frontal sinus, sinuses. Frontal sinuses are located within the frontal bone. So they're located here above the eye socket. This is a nice side view. And then we have, of course, from the front view, we've got one on the left-hand side, one on the right-hand side. Those are our frontal sinuses. So gaps or holes within the bones of the skull. The next thing that I want to discuss is going to be our maxillary sinuses. Well, maxillary sinuses are located within the bones known as maxilla. And you remember that this was, of course, located here underneath the eye socket, and it's actually probably the largest of these paranasal sinuses that we're going to look at. And we have one on the right-hand side, one on the left-hand side. The next one that we're going to talk is actually kind of a little different from these. It's a little harder to position because you need to do a little bit of a three-dimensional thinking. So it's inside the skull, so it's not really as standing out easily as these others that we have looked at so far. This is going to be the sphenoid sinus, and of course it's going to be within the sphenoid bone. So not on the side of the skull, but inside here. And we can add it also on this diagram, but it's deep in there, so it's not super easy to see. The final group of sinuses that I want to add to this diagram is known as ethmoid sinus or sinuses, or sometimes as ethmoid labyrinth. I just personally prefer to use the version of ethmoid labyrinth because it really describes what's going on there. So within the ethmoid bone, we've got a bunch of these little cavities, and they all connect to each other. So that's why they look more like a labyrinth, or can be viewed more as a labyrinth on this sense. Well, you ask me probably, if you're anything like me, you're trying to figure things out, you might ask me that why do we have these paranasal sinuses? Why do we have gaps in our skull? And there's many explanations. Some of these explanations are better agreed. Some of them are still a little bit more of a hypothesis level. But one that's very well agreed and we all kind of recognize is that these sinuses reduce the weight of the skull. If skull was solid bone, it would be very heavy for our neck to carry. Think of, for example, of the bird skeleton. So they're able to fly because the skeleton is so light. The other thing that we can definitely see is that the paranasal sinuses contribute to your voice sounding like your unique voice sounds. So they play a role in voice resonance. The third one that I'm going to introduce to you is something that some people have really agree really nicely and say that yes, that makes sense, and some people are not quite as convinced. So I'll let you make your own choice how you feel about it, but I'm going to cover it regardless. So what I'm going to try to draw here, this is going to be a car, and you know that if you have ever had a chance, hopefully you haven't had a chance, if you have ever found yourself in a car accident, one thing, if it's a front-on-front collision, that you notice that happens is that the front of the car actually collapses, kind of gives in. And that's actually a design of the cars on purpose. And the idea with that is that by front of the car giving in, that absorbs some of that force that has to be absorbed. Rather than hitting hard to the driver and passengers, let's absorb that force so it's not as strong and doesn't cause as much damage for the driver and passengers. So same theory has been proposed for having these gaps, these sinuses within the skull, that if one was to fall face first or get impacts, run into an impact face first, they would absorb some of that force that the individual would be exposed otherwise. And the final explanation, which does make sense, is the immune system role that these sinuses have. And we can see that immune system role explained with the condition known as sinusitis. So if you remember our discussion about how medical terminology works, whenever it's itis, it's an inflammation of something. And in this case, of course, it's going to be an inflammation of the sinuses. Another thing that I wanted to add just quickly on our diagrams of structures to know is the opening of the auditory meatus. We find that within the nasal cavity as well, and that's a connection from the nasal cavity to the inner ear. And on the that is needed to balance the pressure difference that can sometimes cause your ears to get clogged. For example, if you're on a plane and that climbs altitude, or you might even drive up to a higher altitude, or go through a tunnel where there's a pressure difference. So through that auditory meatus, we're able to balance off that pressure difference between on both sides of the tympanic membrane. So auditory meatus would be located roughly somewhere here. Oh, I thought that I had pen on. Let's add the pen so it's going to be easier to find. Roughly somewhere here. So it's a hole that starts from the nasal cavity and runs all the way then to the inner ear. So we already talked about these functions of the nasal cavity, but I do want to highlight them again. So all this mucous membrane lining of the nasal cavity, it's sticky, wet, very thin, rich blood supply surface, and that rich blood supply causes that we get nosebleeds, facilitates that we're able to, first of all, filter the air. So mucous membranes is sticky, and anything that shouldn't be going past it gets stuck on it. It also helps with heating up the air. Like I said, there's a lot of blood vessels coming here, and it's not as thick as skin, so the air is able to pick up a lot of warmth from the mucous membrane before it enters further down the respiratory tract. And the final thing, it is also able to humidify the air before it enters further into the respiratory tract. And one thing that you can consider when this does not work, think of breathing in air on a cold winter's day through mouth. And if it's cold and dry air, you notice that you will probably start coughing if you take a big breath in. And that's because our rest of our respiratory tract is built up and is in an expectation that the air that enters in is going to be heated and moistened. So if that doesn't happen, if we don't breathe through the nasal cavity, that can cause issues. The next structure that I wanted to talk in our review of the parts of the respiratory tract is going to be our pharynx. So pharynx is made of skeletal muscle, and it really is just a tube that we notice. And it starts from the back of the nose and runs all the way to the next structure, which is going to be the larynx. And again, I'm drawing a quick diagram here. The nose, mouth, jaw, rest of the head, a nasal cavity here, floor of the nasal cavity, palate, oral cavity as such. And what I wanted to do was to separate the three parts that form the pharynx. So the first part that we're going to see is going to be known as nasopharynx. So nasopharynx is located immediately behind the nasal cavity, so covering this area here. Then we have oropharynx. Oropharynx is located immediately behind the oral cavity. So it's gonna be located on this diagram here. And the final bit is the part that's before we get to the larynx, which is sometimes known as our voice box. So that's gonna be our laryngopharynx. So let's add that there. So these three parts of the pharynx are labeled here on this sketch that we just did together. Okay, let's continue our journey. And the next one that we're going to look at is going to be actually the larynx. So larynx is sometimes referred as our voice box, but we're going to cover a lot more than just the voice box. It's located from the third to sixth cervical vertebra, and it actually superiorly, so at the top, attaches to hyoid bone. I don't know if you remember hyoid bone from when you covered the bones of the body. It's one of these little odd bones that it's not physically connected to any other bone. It's just kind of floating in there at the neck. You can sometimes be able to grab it even if you feel on your own body. Don't do it for someone else, they get upset, but on your own neck you might be able to do that. That's the bone that gets usually easily fractured if someone gets strangled to death. So that's why it's used also in forensic use, but it's not definite sign. Sometimes you can get strangled without it breaking. Sometimes it can break even if there's no strangulation going. But what we're going to look on this part when we discuss about the larynx is that a larynx is made of multiple different things. There's muscles, elastic tissue, and then there's various different kinds of cartilages. And we're going to be focusing on these cartilages because they are probably the most important ones out of these. And we're going to start the review with the thyroid cartilage. So the name might give you a clue what to expect and where to expect to see it. So if we sketch it together, it's kind of a little bit like a heart shaped from the superior part. So this is the front view. I'm going to draw a side view here as well. So it's not fully closed as a side view, but it's kind of this C-shaped that it hides a bunch of structures inside. The other thing with the thyroid cartilage is that we find this prominent protrusion, which is known as Adam's apple there. So we can see it also on this diagram. And that's typically larger on males than females. That's one of the characteristics that helps to specify between males and females. And if you want to think of one more way of locating your thyroid gland. Of course, you can think of locating your thyroid cartilage. You can, of course, think of where the thyroid gland would be. So it would be here as well. So we see this butterfly shape with the isthmus connecting the two sides. So any of those might be useful as you're working out the thyroid gland. The next cartilage that I wanted to speak quickly about is going to be cricoid cartilage. Cricoid cartilage is the only cartilage of these structures that we're going to go through for the larynx that's fully closed ring. And it's the most inferior part, so the bottom part of this structure. So that's the only fully enclosed ring. All others are open from the back. And then we're going to start looking at the structures that are actually inside this space formed by the thyroid cartilage. So let's start by talking about epiglottis. So epiglottis is this flap-like structure. So we can see it here from behind, but even on this side view, we can really see the flap shape of it. And what epiglottis does, it seals off the trachea, so the airway to the lungs, whenever we swallow liquids or we swallow food. So we're able to make sure that food doesn't go into lungs or drinks don't go into lungs. At all other times, though, epiglottis is open, so securing the airway is the priority. That's what we always want to do in terms of ensuring that one is able to get air going in. So all of those are single structures. There's only one of those. But now we get the structures where you get two of those, one on the left and one on the right side. And the first one that I'm going to talk about is going to be the arytenoid. Arytenoid is at the posterior side of this larynx that we're talking about, kind of a triangular or pyramid-shaped structure. The other thing that's worthwhile to notice from that is that there's multiple muscles, or there's a bunch of muscles that attach to it. And these muscles play an important role because they help us to move this arytenoid a little bit, so it's able to kind of rotate around its own axis. And the reason why this, then again, is so important for us is that vocal cords are attached to the arytenoid. So by moving the arytenoid, we're able to alter the tightness of the vocal cords. So we can add M here to this diagram. And there's actually going to be two sets of vocal cords, but we're going to talk about that a little later. The last two structures that I want to talk first, I want to talk about the corniculate cartilage. Corniculate cartilage is this little tiny tip on top of the arytenoids, so there's not too much to know about that. One on the right, one on the left-hand side. So here, and then I wanted to mention the cuneiform cartilages, just in the name of completedness. Cuneiform cartilages are actually located within the mucous membrane of the larynx, within the thyroid cartilage. So it's sometimes not as easily visible, but there's one on the left, one on the right hand side there. Now we get to look at the functions of this structure. And what we notice, there's a few different ones to note. Probably the most important one for our discussion is that it's the airway passes through this. And of course, we also separate the path for the food and for the air. So we make sure that both ones go where they should be going. The third function that I've listed here, which is what we're going to focus now a little bit, is the vocal cord function. And what I'm going to do now, I'm going to come back to this listing, but I want to show you that I'm going to draw a diagram for you where we're taking a cross section from this area. So we're cutting this in half and looking in like we would be looking from top down. So I'm going to draw a diagram of what we would see in that case, and we'll have a look of it together to identify some important structures. So here, and let's start by adding, of course, first of all, our thyroid cartilage. On this diagram, I'm going to add so that the front, so anterior side is here on the left and posterior side, the back at the right. So let's add our thyroid cartilage. You remember that that was the largest of these cartilages. It formed kind of this structure within which other structures were. And this is not going to be fully to the scale, but it's going to be good enough for our purposes. We also saw our arytenoids, so those triangular structures, cartilage parts, and we remembered that there was a bunch of muscles that were connected there and helped us to move these around. So those are just my muscles showing how they can be moved around their own axis. And the next thing that I'm going to add there is these vocal cords. And there's actually two sets of two pairs of vocal cords, but I'm only going to draw one pair because it's going to be easier for me to explain what we're doing. What we're finding is that these vocal cords are made of elastic fiber. They're white in color, which tells us that there's actually no blood vessels within the vocal cords themselves. The space between the vocal cords is known as glottis, or if you want to use the proper term, it's glottis. This space between the here, and this is where the air would go through, and the vibration would be generated in response to how tense or loose these vocal cords would be. And I mentioned that there's two pairs of these vocal cords, and let's have a look of that. So the first ones that are more superior are known as false vocal cords or vestibular folds. The third false comes from the fact that they don't really contribute to the generation of the voice. And the inferior ones, which we see here, are actually the true vocal cords, also known as vocal ligaments. And that's the ones that really play a role in the production of the voice. The next structure that I want to talk about is going to be our trachea. It's about 4 inches long tube connecting from the bottom here, from our cricoid cartilage that we saw here, and running all the way down to the lungs, where the lungs start. And let's do a quick sketch here to just kind of put us on the map of what we're looking. So here we see the cricoid cartilage, and then we see the trachea running down, and it's going to divide into 2 branches, which are then going to enter into the lungs. So these are then the lungs, and I'm going to talk more about lungs a little later, so we'll just leave them as a sketch as such. What we'll notice about the trachea is that it's a very flexible structure, so it's able to move a lot. But one thing that's very striking there is that we find these cartilage rings that are C-shaped rings for the entire distance of the trachea. And again, we're going to here take a cross-sectional view of this diagram that we just worked on. And I'm going to cut it from here, and we're going to look as if we were looking downwards from the very top. And what we'll end up seeing, I'm just going to draw a head here. This is not going to be to the scale, but the head to help you to notice the left side is the anterior side and the right side is the posterior side. So you see the nose and eyes there. Well, these C-shaped rings of the trachea, what you'll notice is that they're located so that they're open to the posterior side. And you might wonder that why is this important? Why are they not fully closed rings? And that would be a very good question to ask. Well, the explanation for that is that trachea is located here more anteriorly, and behind that we have oesophagus located. So the tube that carries the food to the stomach from the mouth. And normally oesophagus is squashed closed when it's not used, but we all know that sometimes we take big pieces of food that might be almost a little bit too big for us to swallow, but so that it can expand bigger, it's able to actually expand a little bit inside the trachea through this opening if we need to swallow something that's very, very big. So that's why there's that opening behind. Couple of terms that I wanted to show here, and I think these terms will come up in a few other places as well. The term carina. Carina is the term that we use to describe this division where our trachea ends and then that divides into two branches as we see here. So this point where it divides into two is gonna be our carina. So it's kind of this sharp pyramid shape. And what comes out of there is two primary bronchi. So they're the first branches that come from after that. One thing that you'll notice is that the right one is in a steeper angle than the left one. And this is actually going to be important for us. Because of this right one being on a steeper angle, this is where we all normally find, for example, if infants inhale a foreign object, it tends to go into the right lung. So that's the explanation for that. And I think would make a nice exam question. A clinical example that I've given here relates back to the issues if we have a blockage somewhere higher up on the respiratory tree, let's say here, and air is not getting through. Sometimes we might need to make an incision to the trachea to allow the air then to flow in through there and also flow out as needed. So that's what the tracheotomy is. Next, I want to talk a little bit about these branches that we saw, and I'm going to just expand a tiny bit on those. So the first branches that come from the trachea, I need to get the right tool out, are going to be known as bronchi. So we have primary bronchi, secondary bronchi, and tertiary bronchi. Then we have bronchioles and eventually terminal bronchioles. They're just smaller versions of the bronchi. And at the very end, we end up finding our alveoli, and we'll talk about them a little more a little later. But basically, if you look at it, respiratory tree is really like a tree turned upside down. Here's our trachea dividing into primary bronchi on right and left side, then dividing into secondary branches, tertiary branches, bronchioles, and eventually to the terminal bronchioles, which is where the alveoli are located. One thing that we notice as we follow this arrangement is that the amount of cartilage decreases as we move downwards and the amount of smooth muscle increases. So that's something that we notice here as we follow this path of the respiratory tree. The next structure that I want to talk about is the lungs, but I didn't mention this term, so I want to cover that as well. The term was hilum. So hilum is this part, if we add the lungs to our previous diagram here of the respiratory tree, so our lungs would be here. This part where the primary bronchi enters into the lung, that's known as hilum. So these spots here. Next, I wanted to talk about the lungs, and there's a few things to talk about them in there. So lungs fill the entire thoracic cavity with the exception of the mediastinum. So mediastinum is where the heart and great cardiac vessels are located. So that's not filled by the lungs, but everything else is. So let's add our heart here. You remember it was this cone-shaped structure. And then we have a bunch of vessels there. And you'll actually notice that the heart takes a little bit space away from our left lung. So left lung is going to be smaller for that reason. There's a few structures that I've listed here. I want to focus on talking about the apex. So you remember the apex of the heart was this point that was pointing anteriorly to the front, inferiorly to the downwards, and to the left. So it was this point that we had a look earlier on. The apex of the lungs is actually the most superior parts, these sharp, the triangular ends there. So apex can be in anywhere, but it just describes the shape, the tip of an anatomical structure. The other structure that I've listed here is the base of the lungs. Base of the lungs rests on the diaphragm. It forms the inferior surface. And then I've also mentioned the hilum, and we already talked about the hilum, but for the sake of completeness, since I have listed there, we remember the hilum was where the primary bronchi entered into the lungs. And there's a couple of other structures that I mentioned there. You can have a look of those if you so wish to do. We're going to discuss the lungs a little further. So what we're seeing here is some key characteristics of a typical set of lungs, and we're going to go through those. Remember though that there is individual variation, so everything isn't this black and white. You might end up seeing some variation from this. But on this review, what we want to focus is that we have left and right lung, and they differ from each other. And I told you that you had a heart, which took quite a bit of the space from the left-hand side. And this indentation that's left on the left lung here, that's going to be known as the cardiac notch. And that makes the left lung smaller. Well, we have certain fissures that we're able to see. And you remember fissures from the brain, anatomy of the brain. When we looked at the surface anatomy, it was this drop on the otherwise smoother surface. So that was the fissure. So we find fissures also on the surface of the lungs. On the right lung, we have horizontal fissure and we have oblique fissure. And because left lung is smaller, we only end up finding typically an oblique fissure. But these fissures are going to be important and useful for us as we are naming the different lobes of the lungs. So let's go through those. So we have our superior and middle lobe separated on the right lung by the horizontal fissure, and then the oblique fissure on the right lung separates the middle and inferior lobes. Because left side has only one fissure, we're going to have a superior and inferior lobes there only. Okay, let's continue our discussion about the lungs. And what I want to mention about the lungs next is a concept that explains some of the physiology that we'll end up seeing. So I'm again drawing, there's the trachea, primary bronchi, and our lungs here. But what we end up noticing is that lungs are surrounded by pleura. And pleura is made of two layers and liquid that remains in between them. So we can add those layers onto our diagram here. And we have the inner visceral layer and the outer parietal layer that we notice there. And in between these layers, we've got fluid there. And this fluid serves a bunch of different purposes. It lubricates these layers so they slide nicely past each other. It also provides a little bit of cushioning there. But most importantly, it generates what is known as the negative pressure between these layers. And this negative pressure is going to be important for us as we are trying to understand the physiology of the lungs. So this negative pressure is a force that causes the lungs to be pulled to be as large as they can be towards the lateral surfaces of this thoracic cavity. So the negative pressure generated by the pleural layers keeps the lungs expanded. And what can happen sometimes is that you have a puncture within the pleura, and as a result of that, the lung would collapse then because there's no this negative power anymore, keeping it extended. So that would be pneumothorax. So a clinical example that I've given there. And the last anatomical structure that I want to talk with you guys is going to be our alveoli. So alveoli are these final ends of the respiratory tree. So they form actually the majority of the volume of the lungs. So if you, again, we think of our drawing that we could do with our trachea. I'm going to move to this side. With our trachea coming down, our primary bronchi, secondary, tertiary bronchioles, and terminal bronchi. So right at the end of the respiratory tree, we end up finding this lump of alveoli. They're like little sacs or balls piled into there. And we're going to take a section again through one of these and zoom in to have a look what's going on in there. So let's take a section from here, and we're looking just of a very, very small area, and we're extending that on a microscope here so we can see what's going on. So alveoli are very thin walled. There's only a very thin wall there, and that's really the end where the air travels, the final place within the lungs, the smallest area. So you'll notice very thin walls. And another thing that we'll notice there is that there's a rich capillary supply of the pulmonary circulation capillaries. So there's a lot of these capillary vessels running on this area. So they're highly vascular. And because the capillaries have a very thin wall and our alveoli have a very thin wall, that allows that we're able to exchange really easily materials between the two. So this is the side of the gas exchange. The oxygen moves from the lungs to the capillary blood, and the carbon dioxide from the capillary blood back to the lungs and then gets breathed out. Now we're going to have a look of the physiology of the respiratory system. So we're going to talk about the phases of respiration. And this is going to bring in some concepts together. So phases of respiration, we're going to look at 4 of them, but there are more, or they can be organized in a different way. So I leave it up to you if this is the best description, but this is how we're covering it on this course. So the first phase of respiration that we're looking at is pulmonary ventilation. And pulmonary ventilation really covers only this part, bringing the air from the outside the body into the lungs and all the way to the alveoli. And let's discuss a little bit about this bringing the air in, what that means and how that works. And to discuss this, I'm going to draw a series of diagrams. They're all going to be the same. So we've got here our respiratory tree, and we've got our lungs. And again, respiratory tree, primary bronchi, and our lungs. And again, once more, trachea, primary bronchi, lungs. And let's have a look what we can learn by studying these. So let's start by talking about the process of inhalation. So breathing in. What happens in inhalation? So when we are breathing in, we have to actively work. We have to put in effort for that to happen. And when we're breathing in, there's muscles known as external intercostals. So the muscles between the ribs and external branches of those that play a role. But more importantly, this diaphragm that's normally kind of dome-shaped muscle flattens out. So it goes down. And the reason why diaphragm is something that I want you to focus is that it is the main respiratory muscle. That's the biggest muscle in terms of its contribution and function to breathing. So what happens now when we are pulling the ribs to make the chest cavity bigger and the diaphragm goes down? Well, you remember the lungs always followed, we stretched them as much. So now lungs grow bigger as a result of breathing in these external intercostal muscles and the diaphragm doing their job. Well, as lungs grow bigger, that's of course active process. We have to put in effort on that. The same amount of air that remained in the lungs is now spread out in a larger space. So as a result, we're going to end up with low pressure into the lungs. And outside is going to be then in comparison high pressure. And air always flows from areas of high to low. So air will flow into the lungs, and that's how we're breathing in, simply by making these lungs bigger. So it's an active process. Now, if you take a big breath of air inside and completely relax, air comes out almost automatically. So that is going to be a passive process. We don't have to put in extra effort for breathing out. What causes us to breathe out is the elastic recoil of the ribs and also the surface tension. So in this case, the lungs now become small again. They become to the size that they were earlier on. We don't need to put in any effort to make that happen. Well, as the lungs are becoming smaller, the same amount of air that we had in the lungs now needs to be packed into smaller space. So we're going to generate high pressure inside the lungs. Outside the world, it's going to be low pressure in comparison, and air flows from areas of high to the areas of low. So we're breathing out in this manner. Of course, we can sometimes go beyond what would be the normal breathing out, the expiration. That's called forced expiration. In this one, this is active, and we actually recruit some muscles to assist us with this process. So the muscles that we're going to recruit here and we're going to look at are going to be our oblique abdominal muscles, transverse abdominal muscles, and internal intercostal muscles. What these muscles allow us to do, so let's add those here. they allow us to make the chest cavity even smaller than what it would normally be. And as a result, now we get lungs that are even smaller than what we saw in the expiration. So they're really, really small. We're now on purpose making our lungs as small as possible. And the concept is same as we saw in the expiration, but this is just more forceful. There's going to be high pressure because the same amount of air packed into a small place, low pressure outside, and air is going to flow out. But now even more forcefully because we have these muscles assisting. So that's our process of the inhalation, expiration, and forced expiration. What I want to talk next is actually going back to these phases of respiration, and we're going to talk about gas exchange. And we're going to talk first about external gas exchange. So it tells you that we're going to talk about internal gas exchange later. External gas exchange takes place here between the alveoli and the capillaries of the pulmonary circulation. So we're changing those gases. And the direction of how we're changing the gases is that we move oxygen from the alveoli to the capillaries, and we move carbon dioxide from the capillaries to the alveoli. And the driving force for this is the difference in the pressures. So this difference that from the high area materials move to the areas of low, what we just looked at. So it's the partial pressure difference between the areas that's the driving force for the movement of these gases that we saw there. And this is, of course, the external gas exchange within the pulmonary circulation. So notice that that's what we're looking at here now. Well, the next step is going to be gas transport. So that's now our systemic circulation that moves the gases around. So they travel now to the rest of the body, and they reach eventually tissues or interstitial space. And we're now going to do the internal gas exchange. And what happens in internal gas exchange is that the gases move pretty much to the opposite direction that we saw before. So oxygen is given to the tissues and carbon dioxide is given to the blood. So it's the same gases, but to a different direction. And if you do want to mark it on this diagram, well, we would be talking about this spot here. Here, as you see, for the exchange of the gases. So that covers the phases of respiration. However, what I do want to show is that when we often talk about the phases of respiration, we talk about them in these stages 1, 2, 3, and 4, as if air moving this way. But of course, air can move the other way as well. So I guess you could talk about 4, 3, 2, 1 if you wanted. So it's not just a process that ends there. The non-respiratory air movements, we already looked at those earlier on. So I'm going to move on straight away to a couple of terms that I thought that were important. So a term surfactant, that's actually a complex formed by the lipids and proteins. And what it does two jobs. It reduces the surface tension at the alveoli and also prevent the alveoli from collapsing. The other term that I wanted to introduce is the term compliance. What compliance does, it is a measure of how much stretch the lung has. That's how I look at it. But I want to talk now and shift our attention to talking about how do we assess ventilation. And the tool that you might remember, that plasticky thing where you breathe in, breathe out, and sometimes it's more advanced. There's electronics and computer at the other end. That tool is known as a spirometer. So spirometer is used to measure the volumes of the patient's lungs. So what sort of volumes is the patient able to produce for their respiratory system? And we're going to go through those next. And we're going to start with tidal volume. What tidal volume tells us? It tells us the amount of air that moves in and out during normal breathing. So when we are breathing as we would breathe normally, we're not doing anything extra. We're just doing the normal breathing. So the amount of air that moves in and out in that. And on this diagram, you'll notice that the tidal volume is relatively small. So we're not breathing huge amounts of here. Our lung has capacity for much greater volumes if needed. And this is now where we go beyond what the normal capacities would be. Now we do that on purpose. So let's start with the inspiratory reserve volume, often abbreviated as IRV. So that's the maximum amount of air that can be forcefully inspired beyond what we have at the tidal volume. So how much above of the normal breathing we can go. And you notice that it's going to be quite a bit that we can do there. The next one that we're going to talk about is going to be then expiratory reserve volume. What expiratory reserve volume, or ERV, tells us, it tells us the amount of air that can be forcefully breathed out. So if we breathe out as much as we can beyond that normal tidal volume, we can go a little further than that. That's what we're seeing there. And the final value that I'm going to add here is going to be our residual volume. What residual volume tells us, it tells us the amount of air that always remains in the lungs, that we can never fully empty all of the lungs. There's always going to be some air within the lungs. And it is the residual volume, what we call that. And let me just take a highlighter and mark it here, this area. Well, we can measure the volumes, but we might want to know capacities. But that's convenient because we can calculate capacities of individual based on these volumes. So let's have a look of how that would work. And the first capacity that I want to discuss with you guys is going to be the inspiratory capacity. So that's basically calculated by adding the tidal. Let's just get that marked here. So our inspiratory capacity here. And that's calculated by adding together our tidal volume and inspiratory reserve volume. So just by adding those two together, we get our inspiratory capacity. Oh, I lost my tools again. Let's try to get those back. Oh my goodness, they keep disappearing. This looks much better now. The next volume, or next capacity that I want to discuss with you guys is going to be the functional residual capacity. So let's add that to our diagram here. It's often abbreviated as FRC. So a little different than we're going to here on this diagram. And that's calculated simply by adding together our residual volume and our expiratory reserve volume. So that gives us our FRC. The next one that we're going to have a look of is going to be our vital capacity. So let's add that to this diagram that we were looking, often abbreviated as VC. So how do you calculate your vital capacity? Well, you take your tidal volume, inspiratory reserve volume, and expiratory reserve volume. So all the volumes that you can breathe that causes for the gases to move. And the final measurement, which is going to be abbreviated as TLC, nothing to do with the band, that's going to be our total lung capacity. And total lung capacity is basically calculated by simply adding together all of those volumes that we were looking earlier on. So we take our tidal volume, our inspiratory reserve volume, our expiratory reserve volume, and our residual volume. So those are the volumes and capacities of the lungs that we can measure with the spirometry. The next one that I'm going to cover just quickly mentioning that, of course, we have some parts of the lungs that don't ever get fully emptied. So some air remains in that respiratory tree that we saw. And some of the alveoli might be non-functional and some air remains on those. Those are known as dead space. And when you add together the anatomical and alveolar dead space, that gives you the total dead space of an individual. And I'm going to go through this concept of gas exchange once more, simply because it is such an important concept. So we remember the external respiration was between the alveoli of the lungs and the capillaries and the blood within the capillaries of the pulmonary circulation. So let's have a look at what happens in the external respiration. Well, the exchange of the materials, as you remember, was driven by this partial pressure difference. And partial pressure difference meant that we are moving materials from areas of high concentration to areas of low concentration until they're equal. So that's going to be the fundamental concept that we're going to use. And we're going to look at here the amount or the partial pressures for separately for oxygen and then for the carbon dioxide. So in your pulmonary circulation, the air or the blood coming from the systemic circulation coming to the lungs, that's going to have 40 millimeters of mercury for the partial pressure of oxygen. Whereas on the air around us, that's going to be 100 millimeters of mercury. So much higher. So for that reason, we went from an area of high to low. So oxygen is going to be moving from the alveoli to the pulmonary capillaries, to the blood in the pulmonary capillaries. So let's have a look now of carbon dioxide partial pressures. Well, the blood coming from the body to the lungs is going to have 45 millimeters of mercury for the partial pressure of carbon dioxide, whereas the air around us has partial pressure for the carbon dioxide of 40 millimeters of mercury. Well, this causes that the gases are, of course, moving from the pulmonary capillary blood to the alveoli of the lungs. So they move the opposite way. And this was our explanation for what happens in the external gas exchange. We're going to go through the internal gas exchange following the same logic. So we're going to go through that a little quicker. Nothing changes drastically. It's the same concept. Now we're just looking the exchange between the blood that flows in the capillaries of the systemic circuit. And then the tissues or interstitial fluid or interstitial space. And let's start again by looking at the partial pressures of the oxygen. So the oxygen is going to have partial pressure of 100 millimeters of mercury as it arrives to the systemic circulation. And within the tissues, we find that there's 40 millimeters of mercury, the partial pressure of the oxygen. Well, you remember materials move from the higher concentration to the lower concentration. So oxygen is going to be leaving the systemic system capillaries and moving to the tissues or interstitial fluid. And the opposite happens for carbon dioxide simply because the carbon dioxide concentration in the systemic circuit blood that comes from the lungs is going to be 40 millimeters of mercury, whereas in the tissues it's 45 millimeters of mercury. So again, from the areas of high concentration to areas of low concentration, so carbon dioxide moves from the tissues or interstitial fluid, interstitial space, to the blood of the systemic capillaries. And that was our explanation for the internal gas exchange. Well, we've gone through that concept a few times now, which shows how important concept it is. And I just want to make a quick note of sharing how the gases are transported in the blood. So oxygen is mainly transported bound to the hemoglobin. About 98% of that is bound to the hemoglobin. The remaining 2% is then within the plasma. For the carbon dioxide, about 3/4 of carbon dioxide is transported as bicarbonate, about 15% as hemoglobin, and the remaining 10% as plasma. Well, where does this become then relevant to us in a clinical setting? Well, that's the concept of hyperventilation. What happens in hyperventilation is that the individual is breathing with very fast and very deep, so they end up breathing out a lot of carbon dioxide, more than they should be. And this can cause issues moving ahead. So if we remove too much carbon dioxide by breathing out too fast, too deep. So in the past, the treatment for that was to give a paper bag that they were breathing in. So they would get some of the carbon dioxide trapped in there and breathe it back into their body. That really covers the respiratory system, and you notice that we spend a long time on that, so that tells you how important it is and how much of weight that has also in our exam. The next system that we're going to go through, and we're going to go through it quicker, is going to be the urinary system. And we're going to start looking at the urinary system by talking first about the kidneys. And in terms of the kidneys, you remember that the main function of them was this blood pressure regulation, but they do play a role by filtering blood, regulating the total fluid, water concentrations or volumes, and ion concentrations. There's a bunch of other functions in terms of the filtering, such as removing wastes, toxins, drugs. When you go for a night out on the town, well, your kidneys are not resting, even though you might. But we're going to start by looking at the kidneys' external anatomy a little bit. And often kidneys are described as being these bean-shaped structures, just larger. And we're going to have a look of what we can see first from the outside, and then we're going to have a look of the internal structures. So medially, the side that's facing to the middle of the body, they are concave. And on this medial surface, we end up finding this renal hilum, this area here. And we have a bunch of vessels on this area. So we have our artery coming in, our vein leaving. If I get my tools back, I'll add it there. We'll see. I think I got my tools back. We also will actually have, interestingly, also nerve supply to the kidney. And we will also have lymphatic vessels draining from the kidney. But really, the biggest thing to notice here is that from this renal hilum that we just marked, we have our ureter coming out, and that then travels to the urinary bladder. So on the medial side. In terms of the lateral side, we've got this convex surface. And one thing that you notice when you look at the kidneys and external appearance of the kidneys is that they are very smooth and shiny from the surface. That's because they're located inside the renal capsule. So they're wrapped up by this connective tissue layer. If you describe the location of the kidneys, they're retroperitoneal, so behind the peritoneum. They're actually much further to the back than most students think. One thing that I really want to highlight here is that we have our left and right side of the patient, and we'll notice that the left kidney is much higher than the right one. And you might wonder what would explain that. Well, we go to look at the other structures that we end up finding within the abdominal cavity, and we notice that the liver immediately above is larger on the right side, so it takes more space there, so that causes the right kidney to be pushed down as well. Now what we're going to do, we're going to actually look at the internal anatomy of the kidney. And to go through that, I'm just going to do a quick sketch for us, and then we're going to use that to guide our discussion of what we're actually seeing. So let's do this quick sketch here, and we're going to color the structures and go through them by using that. So just like we had a cortex of the brain, which was the outermost layer, the most superficial layer, just similarly, kidneys have also renal cortex, so the outermost layer that we can see. And it is going to be visible also in terms of the tissue color with the kidneys. And then the remaining of the kidney, if you wish to think of it more of the inner parts, are going to be known as the medulla of the kidneys. And within the medulla, there's few important structures. We'll discuss those, but the medulla covers all this space that we see here. Well, the structure that I want to discuss first within the medulla is going to be our renal pyramids, or medullary pyramids, if you wish. So they are these kind of a triangular shaped in cross section, darker tissue areas within the kidneys. And then we also see these renal pelvis, which is the collecting area, kind of a funnel-shaped area that collects the products made by the nephrons. And it collects these products from calyx, which were here, these areas, to the renal pelvis, and from the renal pelvis, from this funnel-shaped structure, the urine goes out through the ureter. So those are our internal structures of the kidneys. But really what I want us to focus now is going to be nephron. That's the most important part of the kidneys. That's the structural and functional unit, and actually the most important part of the entire urinary system as we think of its physiology. And I've listed there a bunch of structures that I do want you to be able to locate on the diagram. What I've done to make today a little easier, I've given the diagram, but you will have to fill in what structures we see there. And let's start with the vasculature, blood vessels. So we've got this vessel coming in. This is going to be known as the afferent arteriole. So this vessel here. Then we have efferent arteriole leaving this nephron. And you'll notice that they are connected by another capillary that runs the entire distance. But how I think of the afferent is arriving and efferent exiting. So efferent arteriole there. Now we see that between afferent and efferent arteriole, we've got this network of capillaries, kind of a ball made of a bunch of capillaries, and this is known as the glomerulus. And this network of capillaries serves some important function that we'll talk about in just a moment. But before that, let's go through the parts of the nephron per se. So we've got this kind of a structure that surrounds the glomerulus. If you think that this hand is the glomerulus, the capillary network, this goes around fully of it on all sides. So of course, we're going to see only a part of it in this cross section, and this structure is known as the glomerular capsule, or sometimes you might hear it being described as Bowman's capsule. Well, from the glomerular capsule, we've got this thicker wiggly line coming out, and this is going to be convoluted tubule. And because there's two convoluted tubules, we named this one as proximal convoluted tubule because it's closer to our glomerular capsule. So the other one that we see further away, that's going to be then our distal convoluted tubule. And on this diagram, I drew it a little longer than the proximal one, but there's no reason why there should be a difference in the length. It could be whatever in the length. So that was our distal convoluted tubule. And between the convoluted tubules, we then have our nephron loop, thinner tube, or sometimes known as a loop of Henle. And the final structure that I'm going to mark here is this duct that collects the contents from multiple nephrons. So this receives secretions from multiple nephrons, and this is known as the collecting duct. Okay, now we have labeled all the important parts of a nephron, and what I want to do next, I want to actually look at a little bit of the physiology, what happens within the nephron. So let's have a look of these movements of the materials, and we're going to start with the process that's known as filtration. So filtration is what happens between our glomerulus and glomerular capsule. So some of the contents of the blood that passes through the glomerulus gets taken away from the blood and put into the nephron at the glomerular capsule. The next step that I want to talk about is going to be our reabsorption. And the process of reabsorption then refers to some of the content that we have now in the nephron being put back in to the cardiovascular system, to this capillary that runs alongside the nephron at the nephron loop or at the distal end of the proximal convoluted tube. Well, next I want to talk about secretion. And secretion, let's add that here. Secretion refers to the process that happens at the distal part of the nephron loop or at the distal convoluted tubule, where we put some of the contents from the blood, from the capillary that runs next to it, back to the nephron. And the final step is going to be process of excretion, and excretion is what happens as the end product, the final urine, final pee that leaves the nephron and goes into the collecting duct here. If you are mathematically oriented, if you enjoy formulas, you can work it out saying that our excretion is what we get when we add the filtration, and from filtration, remove the reabsorption and then add the secretion. So that would be the formula for what happens in the physiology of the nephron. So we've done a good job covering the urinary system. I wanna add the final couple of structures and final couple of concepts regardless to that. So let's add measure that we often get in the lab works, which is known as glomerular filtration rate, or GFR. That basically tells us that how well your kidneys work. So it's really a measure of how much blood passes through the glomeruli in a single minute. You might remember that back in the endocrines chapter, we talked about the ADH, which was the antidiuretic hormone. That was the hormone that caused us to produce less pee when that was around. So that made us anti-urinate. And what ADH does, it actually acts here on the distal convoluted tubule and makes the distal convoluted tubule more permeable, which allows materials to flow back into these capillaries around it. So it's a great way of recovering some of the fluids from the nephron. So that's what our ADH did. What I want to do next, I want to go through some of the remaining structures of the urinary system that we should look at. And to do that, again, I'm sketching out a really quick diagram with our kidneys here, the right kidney lower, our ureters running out, joining at the base of the urinary bladder to there, and then our urethra. So let's go through all of the structures that we have left. And we have already before looked at the kidneys. So I'm just gonna color them in this diagram for us. So what ureters are, which we have not yet talked about, they're simply a muscular tube actually made of smooth muscle. So that allows them to pump the urine and make the urine to move to one direction and one direction only. Regardless, even if you're standing on your head, the urine will move not based on the gravity, but away from the kidneys to the urinary bladders. So that's because, or urinary bladder, that's because of the smooth muscle lining of this tube. And they're retroperitoneal, so they're behind the peritoneum. So they simply connect the kidneys and urinary bladder. Let's add our urinary bladder to this diagram. So urinary bladder, oh, I didn't mean to do that. Let's get our tools back. Here we go. Our urinary bladder, really, if you want to simplify things and describe it, is just a temporary storage pouch for the pee. So that's where the pee builds up and gets stored until we have an opportunity to go to the bathroom. And again, it's behind the peritoneum. So retroperitoneal structure located at the pelvic floor. And we'll come back to the trigone in a second. But before that, I want to also have a quick discussion about the urethra. What urethra is It's the tube that drains the urinary bladder and connects it to the outside world. It is a muscular tube, and there's multiple sphincters there. The inner ones are involuntary ones, external ones voluntary. So we're able to control some, not others, of how the urine leaves the urinary bladder. We'll notice that male urethra is much longer than female one, and this is the explanation why females have more UTIs. So it's a shorter distance for the infections, for bacteria to climb up there, and them for the males. So that's why females are more likely to have the UTIs. Now I promised to come back to the trigone, and to talk about the trigone, we're going to take another section through the urinary bladder that we see on this diagram. So let's have a look of what we see there. So this is going to be the urinary bladder. This is going to be the anterior side at the bottom of the picture, posterior at the top, and we'll end up seeing 3 different openings within the urinary bladder floor. So let's color in our urinary bladder floor. That's good enough coloring for now. And what we end up seeing is that more posteriorly, so more towards the back, we see our 2 ureters. So notice that ureters enter the urinary bladder from the base, not from the top, as students sometimes think. And then we have the one opening for the urethra more anteriorly. So that's to remove the urine from the urinary bladder. And what this all looks like, if you have a little bit of imagination, it looks a little bit like a triangle that these shapes form together. And that's our trigone. So trigone is a name for the shape, triangular shape made by these 3 openings at the base of the urinary bladder. And sometimes it can be a useful anatomical landmark. For example, if you go to do ultrasound or something like that. And here on this page, the last concept that I wanted to introduce was the correct term for urination. So we talk about micturition rather than urination. So if you want to be fancy next time you need to use bathroom, you can use say that word. Well, if we look at the urine, what urine is made of, urine is mainly water. So about 95% of the urine is simple water. There's about 5% of various solute, nitrogenous waste, urea, uric acid, creatine, and others that I have listed there. What we want to pay attention is that what we should not see with the urine. So we don't want to see a too high concentration of any of the stuff that we have normally present. And we don't want to see stuff that we shouldn't have normally either present. And a couple of examples of things that we don't want to see in the urine include, for example, blood, red blood cells in particular, white blood cells as well. That would be a sign of an infection of some kind, and also bile pigments. We don't want to see those in the urine. Those would be a problem. And on that note, we get to the last chapter, and this is a little bit of continuation of the urinary system. It's a little bit of a revision from what you should know already from the past, from your introductory bio, and it's a little bit of application of what we just learned. So let's go through it and have a look. The reason why we have to go through this and why it's important to know something about fluid, electrolyte, and pH balance is that we cover what's normal. So when you move to your further studies, you're able to learn what's abnormal. And all living things contain high amount of water. In humans, anywhere between 60 to 75%. We end up noticing that males have a higher water content as adults than adult females, mainly because females have higher fat content and less skeletal muscle mass on average. Infants have the highest amount of water because they have low body fat, low bone mass, and then elderly people typically have the least amount of water in their body proportion. What I want to talk next with you is that where do we find this water in the body? And what I'm drawing here is just a bunch of cells with the nucleus showing up as dark in the middle. And what we'll notice is that about 2/3 of all the water in the body is located inside the cells. So we call that intracellular fluid, the fluid water inside the cells. So we're going to add that to these diagrams here. And the remaining 1/3 of the water is typically located then outside the cells as extracellular fluid. That's abbreviated as ECF. And this can be many different places. It can be as this interstitial fluid that I'm adding to this diagram, but it could be also as a blood plasma or as lymph, if you wish. Well, we're going to go through next some of the key characteristics of water. And again, this should be a revision from what you already know. So I'm not going to spend a long time on those, but I do want to mention them because they're important. And there's some that are even more important than others. Well, first thing that we notice is that the water is an excellent transport media. So a lot of stuff can be transported within the water. So, for example, majority of blood is made of water, and it's excellent for carrying a lot of things such as gases, nutrients, waste products, hormones, and so on. But it doesn't have to be just the blood. In plants, for example, water carries the nutrients from the soil. Two second concepts that I want to talk about are the cohesion and adhesion. Cohesion referred to the attraction of water molecules to other water molecules, whereas the adhesion is the attraction of water molecules to other polar surfaces. And it is the surface tension of the water, thanks to this cohesion, that allows insects to walk on the water. Water also works as a great heat reservoir. So during the day, it's able to bind a huge amount of heat, and during the night, release it slowly. So that's why living at the beach, you get kind of more stable environment, stable temperatures, whereas here in Arizona, nights can get really cold and days can get really hot because we don't have these big masses of water to bind the heat. Water can take three phases: solid, liquid, and gas. We could talk about the phase of the plasma, but that's outside the scope of what I want to do here. And the final characteristic that is important is the fact that water is a great solvent. So water can carry many different kinds of solutes. And it's these two facts that many things can be dissolved to the water and water can carry them is what makes the water so useful and important for us. If we look at those solutes, there's many things that don't dissolve to water, such as glucose, lipids, ureas, creatine. Those are not so much of an interest to us. It's the materials that actually dissolve, because as they dissolve, they end up building charges or forming charges, and these will have an effect on the behavior of these materials. So those are of an interest to us. If you learn nothing else from this chapter, you might want to remember that where water goes, electrolytes will follow, and where electrolytes go, water will follow. So water and electrolytes, or water and salts if you wish to use that term, they are interdependent. So they depend on each other. There's a connection between the two. And when we talk about the electrolytes, that brings us to talk a little bit more about tonicity, and we'll look at that in a second. But before that, I want to talk about how much water should you get in a day. So your intake of water is typically, on an average size individual, should be 2.5 liters in a day, and output of the water should be equal to that. We should have the same amount of water going in as leaves, not more, not less, so that we remain in balance. So what's the driving force for getting water into our body? Well, that's thirst. You get thirsty. So about 2/3 of all the fluids to your body come from drinking. Some smaller amounts from the moist food, and also as a byproduct of metabolic reactions, we perform water. How do we get rid of the waters? Well, that's mainly through urination, again, about 2/3, smaller amounts through evaporation, sweating, and breathing, and a very tiny amount through feces, because feces are pretty dry. The next concept that we should talk about is the osmoreceptor ADH mechanism, and that's kind of a complex topic, so I've simplified our life a little bit. We remember the concept of homeostasis. I spoke about that quite a bit at the beginning of our course, and I said that that's one of the concepts that we will use to explain many other things in our studies, and this is what we're doing here with the osmoreceptor ADH mechanism as well. So remember this homeostatic mechanism, control mechanism loop, where we had stimulus, something changed, that's detected by a sensor. Oh, I didn't mean to do that. That's detected by a sensor that senses something has changed, as is that information to the control center where we had our set point. And if that's off from normal, effector kicks in and we deal with that stimulus then. So let's have a look of the situation where we have too much water in the body. So now you could say that our blood is almost like too watery. Well, we detect that by the osmoreceptors, which are located at the hypothalamus within our brain, and that information gets passed to the other parts of the brain, where we have the set point, the normal amount of fluid that we should have in the body. And we compare this stimulus to this set point, and if it is off, the effector kicks in, and the effector in this case is going to be the pituitary gland, which is going to be secreting less ADH. And if we make less ADH, that causes more water to be produced, or more liquid to be produced in the nephron, and as a result, we end up peeing more. So we get rid of some of that. So that's this complex concept of osmoreceptor ADH explained through our homeostatic control mechanism loop. Let's have a look of the opposite situation where we have actually too little water. So you could say that our water is too salty. Again, it's the osmoreceptors within the hypothalamus that sense that. Information is processed in other parts of the brain where it's compared towards the set point. What's the normal amount of water that should be there? If we notice that we do indeed have too little water, the pituitary starts to produce more ADH. And ADH caused the distal convoluted tubule of the nephron to become permeable, and more water is taken back in. And as a result, we make less pee, so we're able to maintain and save all that fluid. So that's why the homeostatic control mechanism loop is word of learning. We can explain complex concepts with that. Now, I mentioned that I wanted to say a couple of words about tonicity. So there's a little bit to go about that. That I want us to take at least a little of a look. And I'm going to tell you a way how I think of the tonicity. What's my mnemonic? You can come up with your own, and I'm sure you can come up with something better than what I have, but we're going to use what I have on mine. So let's start talking first about hypotonic cells. What happens in hypotonic cells is that, I'm trying to get my highlighter to work, is that the inside of the cell contains more electrolytes and other salts than the outside of the cell. As a result of that, well, water flows into the cell. And as water flows into the cell ends up swelling and might eventually even burst if too much water flows in. So how do you remember this? Well, always try to make things that help you to remember. And I think that hypo sounds a little bit like a hippo. I'm trying to draw a hippo here. I know that it looks more like a pig than anything else, but use your imagination. So my hypotonic cells are hippo cells. So they are these big and swollen cells that we see. Well, let's have a look at the next tonicity situation that we can have. And in this case, we would have isotonic cells. In isotonic cells, there's the same amount of salts both inside and outside the cell. So it's in equal amounts, it's in balance. And as a result of this, yes, some water enters the cell, but same amount of water also ends up leaving the cell. So the net gain or loss is zero. The amount of water in the cell and the size of the cell remains constant. Well, how do I remember this? I think of what does the iso sound, and to me it sounds like I so perfect. And if you're perfect, you don't need to change, you can remain as the same sized cell. And the final tonicity example that we're going to talk about is going to be hypertonic cells. What happens with hypertonic cells? Well, in hypertonic cells, the inside of the cell has actually less salts, whereas the salts are on the outside of the cell. As a result, the water flows out from the cell, trying to neutralize that, get to the balance, and the cell ends up shrinking, and it might eventually even dry up. So how do I remember this? I think of what are people like who are hyper. Well, those individuals are very active, aren't they? They're always running around and doing a lot of things. Well, what happens if you're very active, you're running around doing things? Well, in my world, in my thoughts, if you're super active, you run around a lot, you become skinny. So like you can see in this individual, his shorts are loose because he's the skinny guy. So hypertonic cells are my skinny cells, so they end up shrinking and drying. This is relevant in terms of the recovery drinks. You might sometimes see that they have electrolytes in those drinks that you're supposed to drink after the exercise, because otherwise you might actually end up dehydrated even though you drink more water. And also some of those contents in those drinks help with the enhanced water uptake. And this leads us to talk about the final concept on this chapter, which is the pH scale and pH regulation in the body. So let's just simply revise what we remember about the pH scale and take it from there. So we remember that pH scale runs from 0 to 14, and at the pH of 7, we call that neutral. Higher pH is known as alkaline or basic. And lower pH is acidic. What pH scale really is, and this is where we might continue a little bit from what you've seen in the past. pH scale is a numerical presentation of the amount of hydrogen ions in a substance. So that helps us to understand that if they have high concentration of hydrogen ions, we're talking about alkaline substances. Low concentration of hydrogen ions is acidic substances. Well, if we look at what's the typical pH in the human body, we notice that, for example, for the blood, it's 7.35 to 7.45. So it's the difference of 0.1 pH units, which is a really small difference. So your body does an amazing job of maintaining constant pH. Value, and you can't change that no matter what you eat. You see those weird diets that say that you eat this and you'll change your pH in the body. You won't change your pH. Those foods that you eat just might be healthy. So let's have a look how we're able to maintain this narrow range of pH. Well, the first explanation that I want to discuss is using various chemicals that tie with the acids and bases. This is a very fast way of dealing with this. And in fact, in my BIO181, I actually use with students, we look at various different things, chemicals that we can add to acids and bases and whether they neutralize those really well. And if they do, those are good buffers. Well, the second way, which is not quite as fast, but still fast, works within minutes, is removing some of those hydrogen ions by breathing out them. So that might be one way. And of course, from the urinary system, you remember that the most efficient way of getting rid of the hydrogen ions is through kidneys making urine. That's known as a renal response, and that can take longest of these three that we saw, so anywhere between hours to days even. So thanks to these three response mechanisms, we're able to maintain our body pH within very narrow range. And of course, the clinical relevance of this is that if you have pH that's too high, you go into alkalosis. If you have pH that's too low, you go into acidosis. And I discussed some of the signs and symptoms of that with you guys last week. And the very, very last final thing that I want to mention here is about the fluid therapy. So whenever you go to a doctor, to a hospital, for example, on something more serious, we typically tend to immediately give you intravenous IV fluid, put you on a drip. And the reason why we do this is that we want to make sure that your blood volume is maintained within certain range. Other thing that it's an easy way to inject various drugs and get them quickly into your body and into your circulation. What the fluid that you're given is, it's sterile liquids that include just the right amount of electrolytes so that your body pH is maintained within the desired range. So one could say that it is kind of like an expensive salt water. But I would say that it's a very fancy salt water because it contains just the right amount of those electrolytes, so our pH is maintained consistent. And it is also sterile. So I would dare to say that it's a little more than just that. And that concludes our review of the exam material. Like you saw, there was a lot. This session took a little longer than I had planned, but we have covered everything. And you see the emphasis on what's emphasized on this review session to reflect what I would predict that you see in the exam. And now we're going to jump just quickly back to our PowerPoint that we were looking earlier on. So I want to remind you that for the practicals, you also have the study guides or lists of structures that you might want to review that help you to study. Remember, it's an open book test, so you can take pictures of your practice versions, you can make notes, and you can have those available. These are timed unless you have an accommodation plan in place. I really encourage you to work through those practice versions of the lab practical a couple of times even, so you see all the possible questions from the pool of questions that the actual questions in the test might come up from. You do have the slides for the lecture, or lecture handouts of the lecture slides. And like I said, I'm super happy to reopen extend assignments. Just let me know. I should be on top of that. And now, if you have any new ones, just send me a message on Connect and I'll make sure to get those done so that you get all those points that you deserve. Finally, just a quick reminder, we do offer in tutoring even though we're still working remotely. So you can use the Cranium Cafe. You don't need to have an appointment, and you can work through material that you found challenging with a tutor. And of course, I'm always happy to help. I've been doing that quite a bit with students recently. If you have any questions, you can ask in one of these sessions. You can always contact me on Canvas, and I'm super happy to put aside time if you want, whether it's questions about the content of the course material, whether it's about technical aspects, or whether it's even about the assignments. That's what I'm here for. I'm here to assist you, and I'm really happy to make that time. And usually I'm able to make that time super fast. All you need to do is let me know. And on that note, I think that we have covered everything that I set out to do. We focused on the study guide, as I said, and that concludes everything that I had for this week's review session for the exam 3 and lab practical 3. If you have any questions, just let me know. I'm here now, or otherwise, I just wish you a very good rest of the evening. And that concludes our review session, the final review session of the week for the exam 3 and lab practical 3. I really hope that this has been helpful, and I hope you have a very good rest of the night. Bye.